for the presentations. Okay, perfect. So I'll just skip my introduction. I'll just briefly introduce. I'm Dr. Dimpi Modi Shah from Indore. I'm a junior ops consultant OBGYN, and I am very lucky enough to have kind guidance of these three Bs, or I can say Queen Bees of Indore, Dr. Asha Bakshi ma'am, Dr. Archana Basere ma'am, and Dr. Kavita Bapat ma'am, who has brought this amazing concept of Learn Simply Indore. So without further ado, I will just hand over to Dr. Kavita Bapat ma'am to begin the entire program. She will introduce Dr. Mahesh.
Am I? Okay. It's okay.
Ma'am, I'll just give a brief introduction of you.
It's okay.
You know,
it's okay. I don't need. You push it off.
Okay. So, ma'am, I'll just please someone share Dr. Bapat ma'am's CV. Yeah.
So I don't need it. It's
okay, ma'am. Ma'am, so we'll move forward to the first dialogue with Dr. Mahesh Gupta sir. Please share the CV of Dr. Mahesh Gupta sir. Thank you.
So, okay, thank you so much, everyone. And nice to see everyone over here. And during the COVID time, we have decided that we are the passionate one, the Dr. Bakshi, the Dr. Baser and myself. We are friends for last 35 years in Indore. And we started this 3B series, and we had a great respect and admiration for each other. And there is no doubt that the legacy we continue to inspire others in the generations to come in the Indore. And we welcome you all to the 3B series of Learn Simply from Indore. And our series is basically focused on the obstetrics and gynec, covering important and crucial topics. And we like to bring all the best speakers and innovative minds from the field of OBGYN in India, and making this program more interesting, more informative. And we believe that the learning should be simple, accessible to everyone. And this series is just like that. We are having such a great speakers today, and all of them are directly, indirectly, they are friends, they are good speakers, they are nice persons, and we are love to have them today. And we can join and explore the world of OBGYN together, and we can empower ourselves also and others also to make a difference into the lives of OBGYN. So thank you so much for being the part of the journey. And I am happy to introduce my friend, our very, very important person, Dr. Mahesh Gupta sir. I'm not reading his CV through all those things. Everybody can read it. But what I think is an exceptional surgeon, and who truly embodies the quality of skill, leadership, courage, and expertise. And surgical skills are unparalleled, and his ability to lead, inspire is another important point. Sarjeet, welcome to this program, and we'll have a good dialogue. And you have a unique style, both bold and effective. And you are doing so much in this field by rescuing many and leading in a thrive-flattering emergencies, and your approach of the situation, and very many more things, compassion and expertise you have in this field. So welcome, sir. We'll have a simple dialogue between you and...
Thank you.
Thank you, sir, for being with us. I am so happy to see Haresh Doshi sir also there. I request each and everyone that please switch off their videos so that when the dialogue will be there, so myself and only Dr. Mahesh Gupta sir will be visible in the screen. And allow me to what they call it, record the session on my computer. Am I right? So Doshi sir and Brajbala, please switch off the videos so that myself and sir will be visible. So today's topic is very simple. We are just there to talk on the dialogue of PPH and how surgical interventions are there in between. So welcome once again, Dr. Mahesh Gupta sir, for being with us at 3B series at Indore. And we will love to talk because of your expertise and your intervention techniques, and how your surgical skills are good for everyone who will listen it, because this recording will be on the YouTube and people can learn many more things from you. And so once again, your contribution to the medical community is invaluable. So over to you, sir. First question I'd like to ask, anything which you want to say to all the audience, then we will start the audience. Then we'll start.
Before you ask a question, I must tell you that if you promise me to give two friends like Asha Bakshi and Archana Baser to me in Indore, then I am ready to shift to Indore from Ahmedabad.
Thank you so much, sir. Thank you so much. I am privileged and I am spreading this point to each and everyone that I have that two backbones in my place. Thank you so much, sir.
Thank you.
Thank you so much. So over to you. Can we start the dialogue? So, sir, yeah, our is a very crisp and a very 10, 15 minutes job because we don't want to make it's a large anything, and anything which you want to add on your point, I'll be happy. So how can obstetrician prepare, number one, and anticipate the potential complications of postpartum hemorrhage? Because postpartum hemorrhage, we all talk so much about postpartum, but the important point is when a person like you will give the insight on this subject, that will be definitely a different than what we have learned before. So over to you, sir.
Yeah, see the postpartum hemorrhage from the postgraduate days.
Yeah.
It has created so big scene and it is so scary. So now to come out from that gloomy atmosphere of the PPH, if you mentally prepared or if you anticipate certain cases in which the PPH is more likely. As in RCOG guidelines number 52, RCOG has identified certain cases which called as a PPH precursor cases. In those cases, there are chances of the PPH are more. So if you are mentally prepared for those, when you are dealing with those cases that PPH is likely to occur, then how to tackle that case? So mentally you should be prepared. It is just like driving a car on the highway. Suddenly some obstacle come in your way. You are totally confused what to do. But if you anticipate that our further four-wheeler may have a brake, so you are mentally prepared to brake your vehicle also. So that is about the anticipation. So anticipation is very important. And second thing is certain cases where there are the sporadic cases which likely to bleed. Now, how to follow up that cases and how to manage that case, we'll discuss later part of our dialogue.
Discussion.
So anticipation and preparedness is always important as far as the PPH management is concerned. Because in the midst of the PPH, when your brain is occupied, you are clumsy, so you will not focus properly. So once you will prepare mentally and you anticipate the cases, then it will be easy to manage that case.
To manage the case as well as it. So you mean that we should have a good correct checklist and everything and prepare our mind also and prepare every environment and everything and anticipate all the potential complications of this. Amazing. So what are the basic, see, it's a very basic question, but it will come, the answer will come through you. It will be really good. So what are the initial steps we should think about involving the management of PPH?
So if we divide the PPH in two portions, one is a normal delivery, then PPH, and second is PPH during cesarean section or PPH after cesarean section. So now PPH after normal delivery, here you are most probably you are alone. So what you will do, as soon as you diagnose the PPH is there, then it is not like a British or American protocol that you'll call for shout and you'll call somebody. No, in your operation theater or in your labor room, you have a limited staff. So you will identify the PPH, and what you will do, you will just, after normal delivery, you will clean the vagina, you will clean the uterus with the finger. You massage the uterus. Meantime, your assistant will start the ergotonics, and whatever the ergotonics you will use. And meantime, they ask for the anesthetist and ask for the pathology. Anesthetist is needed to explore the vaginally, because many times it is confusing that this PPH is traumatic or it is atonic. So meantime, the anesthetist will come, then you can explore the patient. And now after normal delivery, there are conventional modalities like balloon tamponade, or some say it is suction cannula. But these are not, I give you a point of caution that these are not 100% curative treatment. But you can certainly buy a time for a major event. If you are using a balloon tamponade, if you are using a Bakri balloon or condom tamponade or the cannula, then you can buy a certain time to arrange for the further, if needed, either laparotomy or surgical management of the PPH. Now, in case of the cesarean section, during cesarean section, if you find, like I told you that RCOG guidelines number 52, where all the cases, PPH precursor cases, like multiple pregnancy, like a big baby, like prolonged second stage, like obstructed labor, like pregnancy conceived with the ART, history of APH, severe preeclampsia, all these cases need cesarean section. So when you are dealing with these cases, during cesarean section, you should be extra watchful and careful, and you should be ready with some kind of interventional surgery or PPH tackling surgeries along with the cesarean section.
Correct.
So that is a two scenario: one after normal delivery,
one after,
and one during cesarean section.
Correct. You are amazing. So basically the initial steps at whatever the setup you are working is another important point. It should not be like that each and everyone in this country will have the high-ended setups with so many checklists, the blue call, the blue code, or the all the code. They should be there. The staff should be trained. But at any setups, the two things which you have talked about, one is about the normal delivery, and other when we are doing in a cesarean section, all the bakri balloon and all the this cannulas should be available. Good, sir.
And certain cases, when you are going for a cesarean section, like severe preeclampsia kind of thing, then you must have a preliminary complete blood count and complete PT, APTT, INR. So if there is a little deviation in this coagulation profile, then again you have to infuse this kind of blood and blood products beforehand going for cesarean section. Otherwise, cesarean section may lead to the worsening of that mild coagulation failure to a full-blown DIC. So in those cases, I suggest that you go for preliminary serum investigations.
So you mean the right preparedness is very, very important. Now, always we talk about so many things. So is there any difference between the active management of the third stage labor, or that is versus what active management is needed into the fourth stage of labor nowadays, which we talk about? So in a PPH, both the things are there. We need management, and actually what difference you feel there is a difference between these two managements?
See, active management of third stage of labor, we are being taught and we are teaching and we have been learned since many years. So basically now we should understand that active management of third stage of labor is for prevention of PPH. It is not a treatment.
Yes.
It is a prevention of the PPH. So now that we have achieved, now everybody is giving some kind of oxytocin in third stage of labor, maybe at the anterior shoulder, maybe at the after coming head, or maybe after delivery of the patient, by any means, but everybody is giving the oxytocin. Now that is a prevention of the PPH. Now more important is a fourth stage of labor.
Correct.
The fourth stage of labor is called a post-placental 1 hour. So post-placental 1 hour is a fourth stage of labor, and most of the time, in other language we say as a golden hour for PPH management. So that is a fourth stage of labor. Now, if you are watchful, or if your staff is a watchful in fourth stage of the labor, then most of the PPH can be picked up at early stage.
Correct.
What happened after normal delivery, once you complete everything, episiotomy and everything, you come and start looking your OPD, and after half an hour, the staff will come that patient is bleeding. Or in case of cesarean section, patient has been shifted to the room and you are relaxing, you are taking your tea and coffee, and meantime, the staff will come that patient is bleeding. So post-placental 1 hour is very important as far as the PPH is concerned. So if you are watchful in that post-placental 1 hour, that is called a fourth stage of labor, then most of your PPH can be easily tackled. That is a one thing. Now, second thing, I promote active management of the fourth stage of labor in cesarean section. And what is that? As you are doing, or as you are giving oxytocin in prevention of PPH in third stage of labor, the same way you have to go for prophylactic surgical management of PPH during cesarean section in fourth stage of labor. Wherever you find that this patient may bleed, most of the time we heard that the twins pregnancy cesarean section done, and evening there was a severe bleeding, then obstetric hysterectomy done. Morning for severe preeclampsia or HELLP syndrome, the cesarean section done, and evening again re-exploration done. So in fourth stage of labor, we should adopt a technique to control or to prevent the postpartum hemorrhage, that should be now propagated. Because it is not simple that all the time you open the abdomen, take out the baby, close the abdomen, and shift to the ward.
Yes.
All the time it should not be done. You have to now be a little more cautious and more watchful. And now all this uterine artery ligation, all compression sutures, they proved beyond doubt that it doesn't affect the future fertility. Now it is proved beyond doubt that either uterine artery embolization or internal iliac artery embolization or uterine artery ligation or internal iliac artery ligation or various compression suture, they will not interfere in the future fertility. Then why not to do during cesarean section if you find a little doubt? That is a basic difference between third stage and fourth stage of labor.
Correct. So we have to be very much alert, prepare, and able to manage many more things into the fourth stage of the labor, as you have suggested all about it. But what are the basic interventions like a general OBGYN? They should be able to do it. It's not like that always that you have to call some skillful person or something like that, like you, but a general OBGYN who are able to do the different types of intervention, they will call all the senior people or the second opinion person soon. But before calling or before giving a referral or anything like that, means in between the time, they should know some interventions.
Exactly.
Exactly. That's what I feel.
Referral to the hair center is some form of escapism, what I feel. It is escapism,
Yes.
some kind of escapism.
Yes.
A person who can do a cesarean section, they can easily ligate the uterine artery. They can easily do the compression sutures. They can easily do my KMG. Now, one more important thing is that we have been traditionally taught the 4 T's are responsible for the PPH, that is tissue, thrombin, trauma, and tone. But for me, the management of the PPH, this 4 T's is to be now put in the museum. We have to identify the bleeding is from either upper segment of the uterus, that is atonic hemorrhage, whether the bleeding is from lower uterine segment, that is the bleeding after the placenta previa or placenta accreta, or bleeding is due to a trauma to the genital tract.
Correct.
So upper segment bleed, atonic PPH, lower segment bleed, the placenta previa bleed. And if these two bleeds are not there, that means patient has some trauma. It may be in the form of vaginal wall trauma, it may be colporexis, it may be rupture uterus, it may be broad ligament hematoma, it may be extension of the uterus during hysterectomy incision. So if you identify basically quickly that it is atonic PPH or lower segment PPH or traumatic PPH, 3 set of the surgery you should know. In upper segment, this uterine atony, the set of surgeries are there. You should promptly do that. If it is a lower segment bleed during cesarean section, different surgeries are there. You should adapt that surgery. If both the things are not there and still patient is bleeding, then you have to treat as a traumatic PPH. In traumatic PPH, the different surgeries to be done. Because most of the time, all the senior gynecologists are mostly talking about the internal iliac artery ligation. This is that I have seen. Because I'm doing the PPH conference, so most of the seniors, they send me the video of internal iliac that I want to show this internal iliac. I tell you that only internal iliac artery ligation only has no role in atonic PPH as well as in lower uterine bleed PPH. Only internal iliac artery ligation has exclusive and very important role in traumatic PPH. If there is a trauma to the vagina or cervix and you can't tickle from below, internal iliac artery ligation is a definite role. If there is a broad ligament hematoma or supralevator kind of hematoma, the internal iliac artery ligation has role. Because in placenta previa accreta, the gravid pelvis, there is exclusively remodeling of the pelvic vasculature in placenta accreta. All the branches of internal iliac, they anastomose with the branches of posterior division of the internal iliac, branches of the femoral, branches of the external iliac, and branches of the aorta. So if you ligate the internal iliac, temporarily there will be bleeding will stop, but after a few minutes, again, the bleeding start. So we should not jump for the internal iliac artery ligation alone in cases of atonic PPH as well as in lower segment PPH. So that is the basic difference.
Correct. So other intervention means right from devascularization of all. You can start right from the uterine
Yes.
artery to the
It's a simple, it is a atonic PPH.
Yeah.
If it is a atonic, meant it is a upper segment bleed. So upper segment bleed is basically a muscle is at fault.
Yes.
So if muscle is at fault, then I have developed a technique called compression and occlusion of the uterine artery. I am doing the compression of the myometrium as well as the occlusion of the uterine artery with a single puncture on one side. So that gives the best result, and we have many publications for that. And at present, in 5 medical colleges, the dissertations are going on for this topic.
Okay.
Now, if it is a lower segment bleed, in lower segment bleed, only uterine artery ligation will never work, because there is extensive anastomosis with the vesical branches, with the pudendal branches, with the vaginal branches, with everything. So in lower segment bleed, you need to have some kind of cervicoisthmic suture. So if you take a cervicoisthmic suture, then bleeding will be easily stopped. Because nowadays, in placenta accreta or even increta, no need for obstetric hysterectomy. We have kept a separate session that no hysterectomy in placenta accreta. Because in Gulf countries, the hysterectomy is not allowed. So they have marvelous techniques to control the bleeding from the placenta accreta bleed. They remove the placenta and they conserve the uterus. So since last many years now, we are conserving the uterus. We are not doing obstetric hysterectomy in all cases of lower segment adjacent placenta. It's not needed. And temporarily, all the gynecologists should learn the temporary tamponade in lower segment bleed in the form of either Follis catheter or in the form of Satinsky clamp. You apply a Follis catheter in the lower uterine segment by puncturing the broad ligament on either side, tie a Follis catheter, all bleeding will stop. Then you can take your call, either to call a senior or you can gradually go for a devascularization of the lower segment.
So everybody is always impressed and seen your surgery as well as teaching in many workshops, and everyone, your technique of Mahesh Gupta's technique of managing postpartum hemorrhage is also popular amongst all the practicing OBGYN, that how you have used the condom catheter and how the bleeding vessels of the uterus, and the way of teaching is always, we all are impressed by the way you put the things, and it's very important topic. And the best part is the innovation of your innovation is not that costly one. That's another important, the country like us, where we want to reduce the maternal mortality at such a level, and we don't want that they should be very costly things we need. So any other point which you want to talk about your technique regarding, we all know most of us, but we'll like to listen from you.
Basically, I developed 3 techniques.
Yeah.
Two of them were published in 2015 in the International Journal of Gynecology and Obstetrics. That one is a popular, this is a compression and occlusion Mahesh Gupta technique, that is COMOC-MG. So in COM stands for compression of the myometrium and OC stands for occlusion of the uterine artery. Because if you see individually, if you are going for only B-Lynch in PPH, then the success rate is 80% to 90%. If you are going alone uterine artery ligation, then again the success rate is 75% to somewhere around 90%. But if you are going both things, then success rate is 100%, almost 100%. If it is done in time. If you are wasting more time and then uterus tissue become edematous, then compression will not help. Then only obstetric hysterectomy is the option. So in PPH, one more thing, the bleeding is neither venous nor pure arterial. It is a mixed kind of bleeding. So you have to cut down the blood pressure in the uterine artery. That is one thing. So by cutting the blood pressure at the ischemic level in the uterine artery, you will get a maximum effect at the endometrium level. So that bleeding will become more venous. And that bleeding controlled by the compression of the myometrium.
Okay.
So with a single puncture on one side, one right side and one left side, you can do 2 modalities at the same time. And it requires hardly 5 minutes. And special suture materials are also available in the market for the same surgery. Why B-Lynch is still not popular? If you ask 100 gynecologists, 100% knows B-Lynch.
Yeah.
But 90% have not done B-Lynch in their life.
They never tried it.
Yeah, because it's little clumsy. It's little clumsy and proper suture material is not ready. So I made a suture material separate for this surgery, so the things will become very easy. And second is the in placenta previa bleed. If you don't know anything, just if you can separate the bladder the use of Satinsky clamp, Satinsky urological clamp, it is used for a nephrectomy.
That can be.
But its shape is such that it can be easily accommodated in the gravid pelvis. So after making a little space in the broad ligament, that Satinsky clamp will be pushed down.
Yeah.
And at the level of cervix, you apply through Satinsky clamp, and it has a 7 catch. If you use only 3 catch, then it will just occlude. It will not crush the tissue.
Okay.
So bleeding will stop. So that was my one more invention.
Yes,
and third thing, if you don't have anything, then just make a hole with a cautery in the broad ligament as low as possible. Pass a Foley's catheter tight.
Yes, yes.
So all the seniors, they are teaching that there is a massive hemorrhage and there is a slow hemorrhage. Nothing like that. I can show you all the videos for that.
I'm sorry that I'm just putting my word to the audience. I'm sorry to, yes, sir. Yeah. I'm sorry to all the audience that it's only the dialogue we are doing it. And definitely you can see all the Dr. Mahesh Gupta's videos at Ahmedabad program also, because he's having a big conference over there on PPH. And another point is already on the YouTube and everywhere they are. As well as some program, we will call it and add it, that thing with our some other program we can see your videos.
The most important thing to me for PPH is just to remove the thought blocks, just to clear your mind. If you remove your old thoughts, then if you do something new, and new things are there. There are plenty of videos in the YouTube. You can easily see that. But you remove the mind from the mind that, oh, it is a very
the mind. We just want to change the mindset. What is in our mind and what we want to do. So the last question everybody would like to know about, that when and where should the patients of PPH should be referred for the additional, because we are talking all those things you are talking about.
That is very important. That is very important. Today only, with the Gujarat government, I had a meeting for maternal death review. MDR meeting was there today morning at the 11 o'clock, and each state government is now very particular about the maternal death.
And
every government is now serious. They are starting internal audit, and gynecologist has to face the question from the government if there is a maternal death.
Absolutely.
So now this question comes that when to refer.
Yeah.
Most of the time, what gynecologists do, that just to save their skin, they refer the patient. They are not thinking that where they are referring the patient, at this place, the proper infrastructure is there or not, proper person is there or not. So now what happened in our Gujarat, just last week, 2 deaths were there because of the shuttling of the patient.
Yes.
I call it a shuttling.
It's a shuttling.
Yeah. So patient went one place, so-called ICCU was there, patient was operated again. Third gravida, PPH occurred, gynecologist did obstetric hysterectomy. Bleedings continue, patient referred to another hospital where the ICC facilities were there. Again, patient second day operated, laparotomy done. Hemoperitoneum was there. Again on third day, patient referred to tertiary care. For same hemoperitoneum and bleeding PV. So now it is very important that where you are referring your patient, and that hospital is properly equipped with all the facilities or not. Because this shuttling of this patient, definitely patient is going to suffer a lot. The morbidity will be very high. So it is very important you find out your nearby, that whenever you want to refer, if in your hospital you have an anesthetist number, you have a pathologist number, you have a radiologist number, same way you have this kind of hospital number also, and you find out the person who can tackle that case. And you involve, it doesn't mean that any hospital is big hospital, but may not have that gynaec facility proper.
Correct. Absolutely.
Ultimately, patient suffers, and that patient, when the second, third reference patient die, then the legal complications are more. So every gynecologist must be fully equipped to tackle the case at their place as far as possible.
So it's a way that you can put in such a nice way. And the maternal mortality of Madhya Pradesh is so high, and that we are worried about. We are second last number in the whole country, and we feel bad about it because the number one reason is the not referred at the right time and where to refer at such a time, that the way you talked about.
Exactly.
That's very, very important. And in a PPH, we need a comprehensive approach, as you have said, about preparedness, anticipation. We need a proper management of the third stage and a close monitoring, and to learn by each and every OBGYN the simple techniques which they can learn. It's not tough to learn many things which you have talked about, I think. And while referring, we should know the determination of the level of care they have, which where they are attending. We should be save ourselves medico-legally by obtaining the right consent, which I always feel about. And
because nowadays now recombinant, the factor 10 is available.
Yeah,
recombinant fibrinogen is available.
7 is available.
Because recombinant prothrombin factors, kind of the 2, 5, 6, some, they are also available.
Yes.
So now we are not dependent on this human FFP or human cryo or human this all the time, because these are now available in the market. We have factor 10, we have this fibrinogen. It's costing only 15,000.
Yes, absolutely. So it's all our responsibility, especially to communicate with the patient and with the attendants also. And the most important, we are supposed to take the proper follow-up. What I feel that once the patient has been referred anywhere, follow-up is also important. Be there with the patient. Don't leave the patient. That's always I feel. And if that will save our skin also, and we can save the patient also. So thank you so much. Any concluding remarks which you like to talk about? We will love to have, and that we can stop the conversation. Thank you so much.
It was a nice dialogue, and PPH is
we love the subject.
Is a subject which is very dear to me, and I'm always working for that. And I'm being people have trust in me, so half portion of the Gujarat, they are referring all these cases to me every day. So I'm tackling this. That's why I'm giving this extempore advice.
Yes, absolutely.
What to do this gynecologist in cases of PPH.
And we all Indoris always admire you, call you at our own person for the workshops and everything. Thank you so much for being with us.
Thank you so much.
Thank you so much. Thank you so much.
Thank you, ma'am. Thank you, sir. Your crisp.
Everybody can open their videos so that
Thank you, Mahesh Gupta sir, for your crisp excerpts on PPH. We are very thankful for the techniques that you have provided us. Moving on to the next talk.
Thank you, Dr. Mahesh. It was really nice and thoroughly enjoyed your dialogue, and looking forward to see you at Ahmedabad and learn a lot from you.
Thank you.
Thank you, Mahesh.
Thank
you, Mahesh, for being here with us. And we'd love to come to Ahmedabad, and all 3 Bs will come.
I made a comment that you and if Asa kind of friends are there in Indore for me, then I'll shift to Indore.
आ जाइए हम चाहते मैटरनल मोर्टेलिटी कम
करनी है हमारे मध्य प्रदेश की एकदम आ जाओ And I am really welcoming all our other guests. Mitra is there, Dr. Sampath is there, Dr. Harish Doshi sir is there. Always lot to learn from Dr. Harish Doshi also. He is a person who can teach instrumental delivery se leke koi bhi subject he can talk in a different manner. So thank you so much for being with us today. And Dr. Snehila is also there. And Dr. Batra is also there. Thank you so much. Over to you, Dimpy.
Thank you, ma'am. Now I'll quickly move to the next talk. I would like to introduce Dr. Brajbala Tiwari ma'am and Dr. Tabassum Dalla ma'am. Dr. Brajbala ma'am, she is currently president and she is the director and the consultant obstetrician and gynecologist at LCH Life Care Hospital Indore. She is also secretary at ISOPAP chapter Indore. Dr. Brajbala ma'am, are you there? Okay. Dr. Tabassum Dalla ma'am, she is president Raipur Obstetric and Gynecological Society. She has done diploma in minimal access surgery ART and she is director of the Jubesta Hospital Raipur. She has received various awards regarding the excellence in medical field and women empowerment by Go India Foundation. Over to Dr. Tabassum Dalla ma'am. Kindly introduce Dr. Harish Doshi sir.
I think Tabassum is not visible. So good evening, everyone. It's a great opportunity to introduce none other than Dr. Harish Doshi sir. Sir is MD, PhD, FICUG, and sir is professor and HOD of GCS Medical College, Ahmedabad, teacher with par excellence, teacher more than 36 years, and he had many publications, 7 books, booklets, 23 books, chapters, and 34 scientific papers. Sir is faculty for more than 220 times in national and international conferences. He was president AOGS 2003 and president SOGO 2004. And sir was organizing secretary for AICOG 2000. In Foxy conference, sir was chairperson in Practical Ops Planning Committee, Foxy, from 2004 to 2008. And sir was Vice President Foxy in 2019, and it's great to have sir on this 3B program. And I must congratulate our 3Bs. We're proud for Indore, not only for Indore, Bakshi Madam, Baser Madam, and Dr. Kavita Mapat Madam for making this program so important. Practical topics you have taken. So over to you, Harit Doshi sir, for your talk on occipito-posterior position.
Okay, am I audible?
Yes, sir, you are audible and visible.
And this screen is there, right?
Yes, sir.
I have to make a full screen. From where I can make the full screen?
Sir, niche.
New share करके करूँ के?
Sir, so what you can do, sir, there's a slideshow, sir, at the top, sir.
Slide,
Just
so
below to animation, sir. Just click it, sir.
but
So
animation के
below to
पीछे वो
animation,
आपका
sir.
ही आता है. Animation के पीछे that comes out this all zoom, right? Headings comes.
Harish sir, right bottom में जाइए, 3 sign
Yes,
दिखेगा.
yes, I will do that. I will do that.
Yeah, right bottom.
Now it is seen.
Yeah.
It is seen.
Yes, sir.
Okay. So
Make it full. Make it full.
no, it is full only. It is my laptop. It is full only.
Not full in our screens.
New share. Should make the new share
Yeah, do it.
or resume share?
Sir, आप उसको बंद करके फिर से join करिए. So that will be the
Okay, new share. I'll do new share, and then okay, screen. Okay, a share. Now again.
Yeah, press it.
Is it coming now?
Yeah, yes.
Full
Thanks,
screen. Okay.
Thanks,
So,
sir.
respected Archana Madam, Kavita Madam, Asa Madam, 3B, 3 stalwarts from Indore. First of all, thank you very much for inviting me for this 3B webinar series. Also, all right, I'm thankful to my chairperson for reading the full my biodata CV, and also Dimpy Madam and all other there at the webinar. Well, when I start this topic, just on the lighter side, on UG and PG lecture, I ask this question to my students. Which are the 3 most difficult presentation in obstetrics? Okay. Occipito-posterior, occipito-posterior, and occipito-posterior. So it is like that in your Bollywood, Hollywood, you can say Amitabh Bachchan is from 1 to 10, and then all Khan comes. So occipito-posterior causes more second stage problems than all the malpresentation put together. This is a Mundroker statement from the great textbook of operative obstetrics by Mundroker. This simply, occipito-posterior occurs in 10 to 15%. Recent literature says that up to 30% at the beginning of labor, it can be OP. ROP is 5 times more common. Out of them, as we know, up to 90% will rotate during labor to anterior position. Our problem is difficult to diagnose before late second stage of labor, that which 10%, 1 to 2% of all 100% will not rotate and will get arrested and to cause you or put you in trouble. So for diagnosis in late pregnancy, we have a standard teaching right from the UG days, that flattening of abdomen below umbilicus, limbs easily felt on both sides of. In a busy practice, sometimes routine practice, we forget this, but if you have this in your mind, you can readily diagnose by abdominal examination only. But this is for clinical teaching of UGs, not even PEGs. Nowadays, we have USG, sonography machine, right, should be there in your labor room. Last weeks, if you, even in your OPD, last weeks, if you have a doubt, abdominal examination, you should do sonography. Ultrasonography, not in last few days of pregnancy, also during labor, intrapartum also, if you have a doubt, you can check by sonography probe, and that is not my statement. It is given by RCOG. Ultrasound assessment of the fetal head position, recommended where uncertainty exists following clinical examination. So this is very important to diagnose it so that you can further plan out or think about the management. Intrapartum sonography. This is one clue. This may not be given in the books. If you do PV, you do if you have a doubt, some advanced labor, caput, molding, you cannot make out the fontanelles because of molding caput. You do 3-finger examination, and there is some false fontanelle. Here it is. It is near the posterior fontanelle. The shape is like this. It is up to 4% of cases, but it is not. It is not connected with the 4 suture lines. The anterior fontanelle is connected with suture lines. So people used to misdiagnose ROP as to LOA and LOP is to ROA. But if you keep this thing in mind, this point, it is very important. Hardly in 4% of cases, the false fontanelle. Lambdoid suture is one more clue that it is on the more curved surface. Sajata suture, coronal sutures are in a relatively straight, not that curved. So that will help you diagnose occipito-posterior. Right. On per rectal examination, to check that the hollow of sacrum is filled with bony head and not only the caput is down. This is one more clue, to diagnose occipito-posterior. I'll come to that later. Clue for diagnosis complete posterior position on PV is that one feels more bulk of head posteriorly due to parietal bones more posteriorly placed. This is an unusual feeling. Normally we do PV, our 90% are interior position. So that what normal PV examination, what is there in your impression in your mind, that does not fit here. And once the delivery occurs face to face, then you realize, oh, this was because in PV it looked like that. So as compared to routine PV in anterior position, the posterior position, you have more bulk of the head posteriorly, and then you think that it is a occipito-posterior. Okay, coming to the tips for management, there is no antenatal management, Postural treatment, knee, hands position is not found successful. Reviews, even Cochrane reviews have not endorsed this. It is not good. It was by one lady from Mumbai, Juliet D'Souza treatment. So this is also important, not in labor, even antenatally at 34, 36 weeks, if you diagnose OP, don't tell patient. 70% will rotate to anterior before the start of labor. Like breech, we disregard before 34 weeks because they convert into vertex on many times, up to 75% after 34 weeks even. Same thing for occipito-posterior. But this position is not good. You can see this, what happens. Who is this gentleman? It is me. I tried myself. 10 minutes they are recommending. This is not possible for our pregnant lady, and this is not useful also. No antenatal management. Then what in labor? Labor, watchful expectancy is practiced, as we know, 90% rotate to anterior. Routine first stage of management, except bed rest is advised if there is early rupture of membranes, which is more likely because deflex head does not fit the cervix properly, membranes balloon out, membranes rupture at 3, 4, 5 centimeter, not at full dilatation. So early rupture of membrane happens, and then you have to give bed rest so like it does not drain out, and prevent premature bearing down. That is common with occipito-posterior. Whatever patient you diagnose occipito-posterior position, always simple, full preparation ready for cesarean section. These are also known to us. In a busy practice, sometimes we forget this, but this all single point is important. Progress of labor is slow as compared to other priming gravida or same parity patient, occipito anterior. Delayed dilatation of cervix. Incoordinate, tardy labor, slow labor. Incoordinate uterine action. Patient will have more backache because more posterior pressure, Axis of the uterine axis, more pressure. Premature bearing down. Multipara patients start pushing. Edema of anterior cervical ring. These all are there in occipito-posterior. We know all this, but we tend to forget sometimes in our busy practice. And early rupture of membranes with excessive caput formation. Okay. As the what is advised is, we know that it is occipito-posterior. The labor is bound to be prolonged. So you have to counsel the patient and relatives adequately that it will take more time. You may get tired. We'll give you analgesia, but you have to be prepared for good trial because 90% rotate anteriorly. So counseling has no option in modern times. With all Google and everything, we have to be very, very good and proficient in counseling of any OBGY, our patients. Okay, if pelvis is good, oxytocin should be used to augment uterine activity. Why? Because weak uterine action leads to occipito-posterior. Occipito-posterior leads to, it is cause and effect relationship. Because of many reasons given in the books that this is interrelated, Uterine action may not be effective and then it will not allow the occipito-posterior to correct. And if it is there, it will lead to weak stimulation of uterus. And if you give pitocin, if it increases, augments the uterine activity, it corrects deflection, drives the head firmly in the pelvic floor, leading to internal rotation, good progress, and delivery. Analgesia, because I told you prolonged labor is there. This was my topic for dissertation when I did my MD. It was MD, not MS that time. 1984. Since then, my 5 students have done this. Painless labor by epidural analgesia. Not in OP, but all cases. It takes care of backache, incoordinate uterine contraction decreases. Even manipulation or whatever forceps, instrumental or cesarean section you can do under same anesthesia. Pain relief in labor allows for prolonged labor. You can give prolonged time. So what was the negative point? The theoretical disadvantage of relaxing the pelvic floor leading to persistent occipito-posterior. But it is not proved by evidence. However, somewhat little increase in instrumental delivery is there. But otherwise, failure of rotation is never with epidural analgesia. So, arrested occipito-posterior, standard teaching, you have teeth wrap arrest, DTA, oblique arrest, that is POP, persistent occipito-posterior, or occipitosacral arrest. Believe me, DTA is the commonest. It may not be exact transverse. It may be just between 2 and 3 o'clock or 3 and 4 o'clock. All you should consider is a deep transverse arrest. What in the criteria, as we all know, it should be second stage of labor, suggest the suture in transverse position, station 0 or +1, +2 maybe, good uterine contraction, but half an hour is gone. Now 1 hour you must give before you call it or document it as deep transverse arrest. Our problem is normally we become impatient and take decision early. It might have rotated if I would have waited for 15 minutes more. If everything is good, fetal ultrasound is good, I can give trial in second stage of labor. So all these criteria fulfills for deep transverse arrest, but most important is the time. That is important. Okay, this is again a point. Do not diagnose arrested occipito-posterior before second stage of labor naturally, and also before 1 hour in second stage of labor. 1 hour you must give at least minimum. If arrest of labor occurs in a late first stage of labor, people used to diagnose my resident, sir OP में है, sir OP में नहीं आएगा. अभी तो first stage है, 7, 6, 8, 9 centimeter. So it is called non-progressive. Suppose arrest occurs, it is non-DTA, it is not arrested OP, it is a non-progressive first stage of labor where the causes may be different, right? So it is not there. So for arrested occipito-posterior, it has to be second stage of labor. If fetal heart sound is good and descent is happening, one can wait even if the rotation is not happening. This is important. Again, proved by this. Some heads rotate very late, and sometimes at the outlet, just at the outlet, you can visualize that it is rotating and coming out. So if apertures are good and nothing is problem, you can wait, and then right at the pelvic floor, baby may deliver. Progress means descent should happen. Not only caput should come out, right? Caput should come out. Okay, there are some bad omens. When you deal with occipito-posterior, which things will you prompt you that this may get arrested? Bad omens. Left occipito-posterior, because against the law, against sigmoid colon, it has stayed there. ROP is 5 times common. So you think that this may get arrested because it's LOP, right? Occipito-posterior sacroiliac joint. The posterior fontanelle between 7 and 9 o'clock, more posterior. So it is likely to get arrested. Anterior fontanelle easily felt on baby. That suggests moderate to severe deflection. And that is the cause for persistent OP. So when that is there, you are not happy, it may give you the arrest. And naturally, the early rupture of membranes. So these are the bad omens in your particular case. If you find this, that thing that this may get arrested. Right. So problem in oxydoposterior is failure of internal rotation. These are the lists given in the books, right? Abnormal pelvis, large head, weak uterine action. It is cause and effect relationship, I told you. Deflection, poor pelvic floor, and early rupture of membrane. What you can do? You cannot do anything for abnormal pelvis. You have to do cesarean section. Again, you cannot decrease the size of the head. Early rupture of membranes is a problem. But these middle three, you can tackle. You can treat them. Weak uterine action by right oxygen drip. Deflection manually. During pain, you push the forehead. It goes down. Flexion will allow rotation. Poor pelvic floor. Pelvic floor is not poor because it is not then giving rotation. You can do digital, manual rotation. Rupture of membranes, you can't do much, but it is not much a problem. But abnormal pelvis and large head, you cannot continue with the trial of oxydoposterior and think that it is the cause of failure of rotation. I should better go for cesarean section. The management. Naturally, as on now, we are doing now, cesarean section, right? Is heading the list, big font size, because people are less trained with all this ventus, manual, forceps, rotation, right? Rotation forceps never permitted now. Rotation forceps happening at present in some of the Western countries, right? Even Killian forceps, every week one Killian happens in UK, minimum one, right? I have done some Killian forceps. If time is there, I will show the video, but not nowadays. It is much people believe it. Craniotomy only when the fetus is dead. But at least first three you can do. And this 2-finger rotation, right? Not full and half end method. That requires GA. And GA may not be there in your labor room when you give trial. So 2-finger, this is called digital rotation. Now everything is digital. Now this webinar and everything, internet and all that. So digital you can say. Digital rotation in the other way is a 2-finger rotation. I think the video should work. This is left occipital posterior, right? Yes, showing on the mannequin, I mean the pelvis and the baby, right? What you do is, right, 2 fingers, not only whole hand or half hand, full hand or half hand, 2 fingers reach the posterior fontanelle with caput molding. There is some hinge, you will get some grease on the fetal head, and then you rotate it on anteriorly, right? You can do that, right? During pain or in between pain, it helps. Flexion and all that, and also do per abdominally by the left hand. The abdominally, the baby is to be rotated. Okay. Face to pelvis delivery. If occipitosacral position is there completely, you can have face to pelvis delivery. Gynecoid and anthropoid shape should be there. Size of the pelvis should be good, and also good uterine contraction. But here the generous episiotomy is must. Again, a short video. I applied the blades. It was occipital fully rotated posteriorly. 2 things you require, right? Not outlet forceps, long forceps, simple, and give generous episiotomy and go for a horizontal traction, not a posterior traction as with other forceps. It will extend the fetal head because now the face is anteriorly. So I am not in a hurry. You can see I am waiting. When contraction comes, then only I will pull. I require the help of push from above also. Mother is also, no, this mother was in her spinal anesthesia, so she cannot push much. So simply you can see the head is slowly extracted. I have all the videos. Breech, face, Gilan. You can see the face has come, right? The face has come. So that was caput molding, big size, right? So the baby is delivered. And I give big episiotomy. So even the guarding of perineum is not required, right? Okay. So at that time, right, baby is crying on table only. No need to worry. I think I switch over the next video. This is vacuum. The manually, digitally it was rotated, and then Mitivac is applied. Mitivac cup is applied. Vacuum is very easy to use, but that leads to problem. People overuse it. My students, one student gave up her dissertation because she was finding a problem with success. But then because they overuse it and pull it excessively, it is a big tractor. It is not as strong like forceps. So this Mitivac is a nice instrument. These two pumps, and the pressure is created. Just 2 pumps manually, and the pressure is created. You can see this. So that is it is somewhat costly, but rather than Scholastic cup, but very easy to use it. Right. Now I'm sitting again, waiting for a train contraction to come. Right. My sister was asking me, should I give, right? Anterior 2-finger support is given here so that it does not pop off. But if you give perpendicular to the cup, it is not required. If you give posterior to the cup, you have to support the cup anteriorly. I have many videos, right? 10 different videos of different malpresentation and vacuum and forceps at vaginal root, at cesarean section, because I'm fond of instrumental delivery. I teach them, but the people don't want to learn. That is the problem. Right? Slowly, the head will come out, right? Just simple, very simple. And when it comes out, you can release the pressure by that manual pump and a cup comes out. And the cup size you can see on this, right? I'll move to the right, okay. Applying in a forceps, when you do for simple forceps after digital rotation, applying forceps, if you're doing it, then only after some waiting and second stage of labor helps in good molding. And even if forceps are applied in little incomplete rotation, as the American College ACOG criteria allows, up to 1 o'clock and right 11 o'clock, 30 degree, even up to 45 degree, you will be successful and it will not produce because there is so much molding. The blade marks will not happen even if it is unrotated head. So if FHS are good, I will wait. When the students call me, I ask them to wait 10 minutes. After 10 minutes, I will get scrubbed, let 3 contraction come, then get molded, then the application of forceps will be easy. Rotational forceps are right, not done for arrested OP position in modern obstetrics. I'll show the video if it runs, but not done. I have done a couple of years back only. Last Kilan. Temptation to apply routine forceps on an unrotated head should be strongly avoided. I have done 100 forceps, so I can do any forceps. No, here unrotated head, it has to be either 1 o'clock or 11 o'clock. Then apply routine forceps. Vacuum is better as it allows rotation to occur, but it requires strong traction. I think I'll minimize this and I will run this. If it runs, okay. Can you see this video?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Yes, sir. So Kilan, I think I'll run from the beginning. All right. Okay. The blades are anterior and posterior. So it was right occipital transverse. The first anterior blade is introduced. It is just a 2.5 minute video. First, the anterior blade goes anteriorly. The lock is a sliding lock here. What I have applied the artery forceps at the bleeder at the episiotomy because I required space. I gave the episiotomy earlier before application of forceps. For outlet and other forceps, I give episiotomy afterwards. Okay. Now, the second blade we have to introduce. The artery forceps is removed. It will come in way. Bleeding has stopped. The second blade goes posteriorly, directly posteriorly. This is a right direct method, right? Not 3 methods of Kilan forceps, but I usually practice this direct method. It goes posteriorly directly, right? It was under spinal anesthesia, primary patient, good size baby. So now the sliding lock to correct asynclitism. Once it is there, I will wait. I will not be in a hurry. I will wait for contraction to come. In between contraction, you rotate, right? Not 3/4. You are giving traction, rotation, and compression already there. So it is said that better you have only 2 forces at a time. So rotate while you rotate and pull while you pull. Right. I waited for contraction to pass off. And now I'm rotating. Now when you rotate, the blades become right and left rather than anterior and posterior. Then again, I waited. In spinal, the contraction do continue, as we all know. No hurry, no hurry. Don't become panicky. Now I have rotated completely. Now it is right and left blade. Good size episiotomy, no guarding support of perineum, much, and baby has come out. Right. So there is Gillan, right, forceps. There was probably, right, little meconium, but you can see the baby will cry with the pediatrician ready. God was there. God was slipped over the shoulder rather than, right, on loose cord. There was. You can go either way. Baby's reflexes, you can see when you deliver the baby by forceps, you don't be a hurry in giving it to the pediatrician. Do whatever meconium suction you have to do. The baby is crying, and right, moving some reflexes. Okay, so I'll go to my slide only. I have to make the full screen, right? Okay, it is there, seen? Hello? It is seen there? Full screen?
Yes.
Okay. So if one is not trained and confident in instrumental delivery, cesarean section is better. Nowadays, everywhere, cesarean section. Now, the incidence is, Asa madam, what do you think? Incidence is how much? Incidence of cesarean section is beyond 100%. How can I say beyond 100%? Because when some of my patient comes before they become pregnant for infertility treatment, they tell me when I become pregnant, do my cesarean section. No delivery. However, there are risks or tears due to difficulty in delivering deeply engaged head leading to postpartum hemorrhage. We had a nice dialogue with Dr. Mahesh Gupta, right, previously. So that, right, PPH is a problem when you do cesarean section, right, in a arrested oxyposterior. So just 2 points for this cesarean section, deeply engaged head. Push method tips are insert the full hand inside. So it will give more depth. 4-finger or 2-finger PV, not much. It may push the head, but not much. And it gives you more strength when you push the whole hand in the vagina. And be ready after anesthesia before painting draping. Now, in a medical college, what happens? The struggles start when the baby is not delivered. Then somebody raises the towel and passes the hand. He may not get scrubbed fully, and that is the problem. So before that is, if you anticipate, do it that way, right? Okay, and push the head before uterine incision. Not after abdominal incision, but before at least. It is an easy way of delivery then. But the better method is a pull method, modified Patwardhan. There was a controversy, Patwardhan, modified Patwardhan. You know, all over the India it is going on, right? I met Patwardhan sir because he was colleague of my teacher, Dr. Narendra Vani, right, in Bombay, right, Grand Medical College. So I went to his clinic, sir. There is a controversy. So people, Bombay examiner says that this is not Patwardhan. So he said in his times, his father, Balchandra Patwardhan, in his times, there was much trial given for any patient because cesarean section was with a good morbidity and mortality 40, 50 years back. So they were giving trial to each patient in labor. So occipital anterior get arrested, not much posterior. So anteriorly went there, the back is anterior. So he delivered by shoulders first, doubling up the baby and original Patwardhan. Okay. Nowadays, we don't give much trial. Occipital anterior does not get arrested. We do early decision. Whatever happens if the occipital posterior, we are hopefully thinking that it will rotate and come out. So we have back posterior, arrested occipital posterior. In that, modified Patwardhan is done. How? The uterine incision should be deliberately kept at a higher level, naturally at the level of shoulders. Pass hand high up in the uterus. Go till fundus. People used to catch the whatever limb is available slightly higher. Right? When I teach my students, they try this, but they don't pass hand much deep. See, always remember the limb of the fetus, which you can easily catch and come out, is the upper limb. Lower limb is not having much mobility. Our hands have much mobility, so we can catch it easily. Lower limbs come with difficulty, and it is there a fundus. Always catch the leg. I always tell that intrauterine, don't shake hands. Intrauterine, pull the leg. Extrauterine, don't pull the leg of anybody. Shake the hands. Extrauterine, right? So wait if there is uterine contraction. This is also a problem. People try and then they give up. No, I cannot deliver by modified protocol because contraction had come, spinal anesthesia. So that is a problem. Okay, wait, if there is uterine contraction, let it go, you will be successful. It is very rewarding, not difficult, and supported by evidence-based medicine. I personally learned from Vasant Patwardhan, he also no more, Vasant Patwardhan, his father technique, devised this technique. Just a word, right, for the teachers like me, it is the responsibility of senior obstetrician teachers to prevent this art from dying. Instrumental delivery. Otherwise, this instrument will soon vanish. That is a scenario. That patient is old now. There you don't want to give cut. But when she was young, you want to cut. Right? Okay. So that is a problem. Ladies and gentlemen, I will end my presentation. Skill is neither a gift nor a luck, not an inherited virtue, not parallel with IQ, never acquired by Eklavya approach. अर्चना मैडम का, आशा मैडम का फोटो रख दिया तो आ गया, ऐसा नहीं होता है. You have to do. Skill never comes automatically. Skill is acquired by proper training under a good teacher and lots of practice. This is my teacher. He is no more. 2 years passed away. He taught us everything in obstetrics, not only the obstetrics, but the morals of right life also. Experience has no substitute. This is just happening in my labor room. This is tug of war. Instrumental delivery, they are doing like this. Somebody is pushing, my residents are there. Somebody pulling from above, so then mother will not go down. And because the girl cannot push, somebody is pulling her. This is should not happen. My humble request, develop passion for vaginal delivery. Price of successful obstetrics is patience. Dynamics of labor always begs for time. And Mother Nature is always the great obstetrician. I always tell my students that when you pass, you are MS, master, but you are not master in obstetrics. In obstetrics, you are mazdoor in obstetrics, not master. Never. Thank you very much. Thank you.
Thank you, sir. It was excellent talk. You covered everything from tips of diagnosis to tricks of management with all video presentation. It was really academic feast for all of us. Thank you so much, sir.
Thank you, madam.
We always enjoy listening you. And our city, Dr. Asha Bakshi and Dr. Archana Baser, great obstetricians of the town. They try to do maximum vaginal deliveries.
Great. Great to hear this. Madam, please continue this.
Yeah, they are doing a tremendous job. Don't ask me because I only deliver uterus through vagina, nothing.
We deliver vaginally so that Kavita has not to do VH in previous section cases.
Great. That is also a problem. Yes, you are right. Thank you.
Thank you, sir. I have heard you so many times, stillbirth and all. I mean, you are just super in your talk.
Thank you, madam. Thank you, madam. Thank you.
Great.
Right.
It reflects on your skills, how good your skills are. And best thing is that you are dedicated to teaching. That is most important.
Yes, madam. Yes, I teach undergraduate also at this age, 65.
Yes. Yes, amazing, sir. Amazing. We are proud of you.
Madam, thank you.
We are proud of you.
Sir की किताबें बहुत अच्छी हैं. They're so good. I've given them away as prizes.
Thank you, madam.
And the most, sir, just a concluding remark about it, which I love to say, that nowadays the youngsters, they want to do more of the fetal medicine, more of the IVF, more of many more things. They should at least, like Israel, they should work 10 years in the obstetric department before doing any other thing in OBGYN. They're supposed to do and they should deliver, and this art should not go. Yes. So I think over to you.
You are right.
Yes, sir.
I think agree, Dr. Kavita. We should not de-learn our obstetrics, what we have done in the PG days.
Thank you, sir. Thank you so much.
Thank you, madam. Thank you, madam.
Thank you, Prajwala ma'am. Thank you, Harish sir, for a motivating lecture. It was so good to see you from books to live in person. I'm really motivated. It's like I want to do vaginal delivery right away.
Great.
So moving forward to the panel discussion, I would like to call upon Dr. Asha Bakshi ma'am and Dr. Archana Baser ma'am. Dr. Asha Bakshi ma'am needs no introduction. She is the lead consultant at Motherhood Hospital Indore and Dr. Asha Bakshi Fertility Center. She is Vice President elect 2022 West Zone Foxy. She has been treasurer at ISAR. She has been member of executive committee at AICCR RCOG, and there is a huge lot of in her CV. So moving to Dr. Archana Baser ma'am, she is consultant obstetrician and gynecologist director at Akash Hospital Indore. She has been vice president of 2020 and organizing secretary in AICOG 2022. Currently, she is a past fellow representative AICC RCOG West Zone. So as we're running out of time, I would like to hand over to Bakshi ma'am and Baser ma'am to call upon the panelists, Dr. Sampat Kumari ma'am, Dr. Sena madam, Dr. Achla Batra, Dr. Anupama Dave, and Dr. Sheila Jamal ma'am as they're here. I think Dr. Kavita Singh ma'am has also joined. Thank you, ma'am. So I guess these are the panelists ready.
Anupama Dave. Anupama is also there.
Yes, Anupama Dave ma'am is there. Yes. Kindly share the CV.
Thank you. Thank you, Dr. Dimpy, for really conducting so well. And we are here with a panel, which is really a surprise. For everyone's information, we have not shared the cases or any questions with our panelists because is our 3B series. Dr. Kavita has already said that we are doing it our speakers. They are thorough in their subject, they are passionate about teaching, and they are very good at their work. So today, our topic of the panel is surprises in second stage of labor. And our panelist team consists of Dr. Sampat Kumari. May I have the CV of Dr. Sampat Kumari? Sampat Kumari, I think Dr. Asha would introduce her best because she's our co-vice president.
Archana, you go ahead with all the introductions and I'll start them.
Okay. I will like to add one thing. She was a co-committee chair with me, such a competitive and such a hardworking girl. But the no beat, but I don't have words. Very, very competent. And nowadays the latest name of her is she is a Chennai Express.
And one that is true, Kavita. And when you're with her, you may take half an hour to get ready, but she's ready in 5 minutes. So that is how express she is. That is Sampat. And always
yes, thank you, Asha and Kavita. You go with the next.
So welcome,
Sampat. One day's relationship, it's a long relationship we all have. Thank you so much for being here.
Welcome, Sampat, and it was really graceful of you to accept our invitation. And may I have the next thing, Dr.
नहीं कोई दिक्कत नहीं है मैं बिजी सब बात हो गई सो रोटी निकले कुछ नहीं कर
डॉक्टर अचला बत्रा
अरे बड़ी मैडम को अंदर ले लो भाई
मैं फोन कर दूंगी तब
बड़ी मैडम कहाँ दिख नहीं रही है लीला मैडम
लीला मैडम की आवाज आ रही है पर दिख नहीं रही है Professor Achla Batra, she is consultant Obs-Gynae Mata Gujri Hospital, Delhi. She is a good friend of us and she is a national president of ANARCHI 2022-24. She is advisor to many committees. She is member of Urogynec Committee, FOXY, chairperson Urogynec Committee, AOGD, a reviewer, international and national journals, and she has WHO pocketbook on first trimester abortions, and she has written chapters in several textbooks. Welcome, Dr. Achla, and thank you for accepting our invitation. And I'm sure your inputs on our case discussion is definitely going to enlighten the audience here. Dr. Mitra Saxena.
I just want to add one line about Achla Madam, our old close friend from ICOG days. And she has worked so much and with a simplicity. And so many, I don't have words much, but I know the person with a simplicity, a smiling face, and always there. In all the programs, you just call her. And thank you so much for being with us.
My pleasure.
Dr. Mitra Saxena. She is so energetic, enthusiastic person. Like Mitra, where she meets with so much of love and affection. Any meeting you go, Mitra will always, welcome you. Currently, she's chairperson, Practical Obstetrics Committee, FOXY, and she has been active FOXY member for last 20 years. She is member of several societies, and her contributions, chapter on vacuum, ectopic pregnancy, she has edited bulletins, numerous online and physical workshops on internal artery ligation. So I think we have a really good selection because she has, a good experience of obstetrics, and she'll be able to contribute to the cases in a great way. So may I have the next slide, please?
Like to speak, the Mitra was with me as I was a vice president. She was with me, a very skillful, very much oriented person who can speak on any subject, and she can write. She is a very good writer. She writes also, and skill and drills in obstetrics, you are at par, and this is a need of the country. I tell you,
she's good at acting
also.
She's very good in acting.
Thank you,
also.
thank you, our 3 Bs. Thank you so much.
Thank you so much.
So it's my great pleasure to introduce young, dynamic Dr. Shehla Jamal. She has so many things to her credentials. She is right now Associate Professor and Unit Head, Medical Education Unit Coordinator, Rashtriya Medical Research Institute, Bareilly. And I had a really good connect with her during my vice presidency in 2020. We did lots of webinars together, and she's always at forefront. You ask her anything, she'll be ready. She'll never say no to anything, be it a paper presentation, be it any competitive things you want to make her even judge. Anything you tell her, she's always ready. And she has many awards to her credit. So welcome, Dr. Shehla, to our panel discussion. And I'm sure...
one-liner from me. Sorry, Archana, I'm disturbing.
We want... because
she is a new India. Most updated, smart, and the most important, can dance, drama, acting, everything she knows. Everything. She is very, very talented and a knowledgeable.
Yes.
Welcome.
Shehla is very good. So welcome. Shehla. Where's Anupama? Dr. Kavita is also joined. Yes. So Dr. Professor Anupama Dave. I'll do it later. So Dr. Anupama is MS, MRCOG. She's from our own town, Indore. She is a hardworking, very passionate person. I've seen, and the one thing about Anupama is very soft-spoken. I don't think I've ever seen in her angry. She was heading and leading the scientific program of AICOG, and we worked till 11:30 in the night. After she finishes her work in medical college, she has received many fellowships. She has more than 15 state and national awards, more than 45 index publication, textbook chapters, and she's a passionate teacher, more than 23 years. So I think we have galaxy of teachers here today to really give their inputs on surprises in second stage, which all the obstetrician fear.
Ma'am, sorry to interrupt. Dr. Leela Vyas ma'am has also joined.
Yes.
We're lucky to have her in the panel discussion.
Yes, yeah.
And another word for Kavita, she is from our own place, brilliant girl, and done a great conference at Jabalpur. So welcome.
We consider Kavita as Indori only.
I know.
Thank you so much. Thank you so much.
So Dr. Leela Vyas,
मैं involved हूँ कि नहीं हूँ?
आप हो मैडम, पर आप दिख नहीं रहे हो. आप ना always on go होते हो, always on the car or on the vehicle. So Dr. Leela Vyas, I think everybody knows.
Another team.
Another team. Dr. Leela Vyas is one teachers of teacher. I think whenever you sit with her in the any conference, post conference, what you learn from her, what are the difficult cases they dealt, and how she taught her students. So she is again a very passionate teacher and very well updated. And I think she has very much practical experience. And Leela is a great friend. She's our Gigi. So welcome, Dr. Leela Vyas, to the panel.
Leela is very energetic all the time. And it seems within few minutes she'll solve the problem. So that is Leela.
I know that. She spreads Leela.
Yeah. Leader. And a very good teacher and very knowledgeable.
Leader.
I have I missed out anything? Anybody? Dr. Yashodhara is not joining. Dr. Dimpy, is Dr. Yashodhara here? No.
No, ma'am. I think she would not be able to join.
So I think we have all our panelists on board except Dr. Yashodhara. So I hand over to Dr. Bakshi to start with the cases.
A very good evening to all of you. And today the topic is very interesting, very practical, and the surprises in second stage of labor. And we all know that second stage of labor is something, sometimes it goes very smoothly, and sometimes, oh my God, you may have problem. It is one of the most intensive part of the delivery for the patient as well as the obstetrician. And it may sometimes be associated with major upheaval. A very good teamwork and trust between the couple and caregiver is critical. However senior or experienced you may be, the second stage sometimes can be associated with complications and surprises enough to shake you, and then you start feeling like, I wish I was never an obstetrician. This obstetrics is so bad, I want to leave it. And then that really disturbs you for at least days together. So these are the problems, and today we have got such good panelists that they are going to really enlighten us with their experience. So let's start with the first case. And this first case is a 34-year-old patient referred from periphery, has been in labor, full-term pregnancy, and there has been failure to progress and fetal distress. The consultant on call applied Ventus, thinking that she is in fetal distress, and there wasn't much time. So only she saw the ultrasound report, and that was 3.3 kg baby. Unfortunately, the baby got stuck at the level of shoulders. Then I was called. I was at home by the time I reached and applied the Roberts menu, gave the Robert position and did the external rotation and got the posterior shoulder. The baby was already fresh stillbirth and weighing 4 kgs. So my few things which I always felt was application of the Ventus appropriate, and this question will go to Dr. Sampath.
Yes, first of all, thank you for the three beauties of indoor, Bakshi and Basser and Puppet. See, application of Ventus was appropriate because 3.3 kg as per ultrasound, it is already mentioned. So always we should be very, very careful. In my practice, after 3 kg, larger than 3 kg means you should be very careful. Rather than going for the Ventus, we should assess whether patient is a known case of diabetes. If she is not diabetes and the pelvis is adequate means, there is no wrong in going for 3.3 kgs for the vaginal delivery. I prefer Ventus rather than the forceps. So I am always for Ventus. So because Ventus will be easier, at least rather than going for the, if you counsel the patients also, the patients if we tell that we are just applying the Ventus, patients are also accepting. Many people, they may not like the Ventus, but I am for Ventus compared to the LSCS or lower mid cavity or outlet forceps. So there is no wrong in applying Ventus for an appropriate cases. That is very, very important. Selection of cases very, very important. And the patient should also have some strength. If applying the Ventus means like just like that, we cannot what to tell. The patient without full dilatation also we can go for the Ventus. So I prefer Ventus. Now it is very easier, and application previously we have to go with the pressure. Nowadays it is not like that. The Kiwi's Ventus like that and all. It is very easier. I prefer Ventus, Asha.
Any precautions would you like to take before applying the Ventus? Would you like to examine per abdomen, assess the pelvis?
Yes. That has to be done, because shoulder dystocia, most of the times, the way, as you, this case, 3.3 kg, it has been as a 4 kg, like that, it is there. By abdominal examination, we have to see whether it is possible or everything. That has to be done. Routine, that only I'm telling, appropriate case selection is important.
Because what I was taught that you must always examine per abdomen and see whether any cephalic part is felt per abdomen.
Yes,
If
the 4/5 palpable, that all 5 has gone, that always before going for application of any instruments, we are going to see. That is abdominal examination, that 4/5 palpable to 5/5. That is very, very done. You should confirm that all has entered into the pelvis.
Can I add something, Dr.
Yes,
Ashavantri?
Yeah.
Dr. Sampath is very right that Vento's application is always, it is to be done appropriately. But in your case, in the context of your patient, where I find that this patient had been, Ventus was applied in the periphery with the estimate that it was 3.3 kg. When you managed the patient, of course, the baby was lost and it was 4 kg. So definitely in this patient, there was some miscalculation between the fetal size and the pelvis and whatever. So probably I think that nowadays, like, I don't know how old this patient is, kitne saal purana hai, but in present scenario, like a person who starts up a vacuum delivery should be well equipped to even manage cesarean, second stage cesarean. So, I mean, a fresh stillbirth of 4 kg baby will not be accepted by the relatives. So I think that there was some a misappropriation in the assessment of the baby, the fetal-pelvic disposition, failure to progress. I'll tell you what, failure to progress in second stage is such a big deterrent for instrumental delivery. Because if it is due to uterine inertia, at that time flogging a tired uterine, uterine muscle, like you're trying to give oxytocin in second stage when there is already dysfunctional uterus, actually it is a recipe for disaster. So I feel that Ventos has to be done appropriately, but in this case, that was a wrong, use. It should have been some other thing, or the person should have been proficient in delivering a shoulder dystocia. Because if you
mean to say that do not rely just on the ultrasound for the measurement.
Clinical examination.
I think your clinical experience is very important.
Clinical examination, engaged head, fetal-pelvic. You cannot do any instrumental delivery without doing a proper per abdomen examination. Where are you hearing the fetal heart? Is it in the flanks? Actually, Dr. Devshi's lecture on occipito-posterior, because it is occipito-posteriors which actually get you in trouble, where there will be failure to progress, and along with there is fetal distress. So one has to really, if you're going to do a trial of vacuum or trial of forceps, you have to be sure that you'll take out an alive baby. So I feel that this case should have been better managed.
Yeah, and if you have a big baby and a diabetic, then never apply Ventus, because if the head would come out, the shoulders are always bigger in diabetes, so they will definitely be dystocia. So whenever for an assessment of the size of the baby is very important when you are applying vacuum, because this is something where you get stuck, and then that is very important.
And the problem here was that this was in periphery. How much she was investigated, we do not know. But it's very important that when it is a diabetic patient, then we have to be very, very careful. This is the only situation where you can predict shoulder dystocia and you can really avoid shoulder dystocia. Otherwise, most of the times, it is very difficult to predict the shoulder dystocia, and it will always come as surprise. So only thing where you can really is gestational diabetes, where you can predict a big baby. And another is when patient has put on a lot of weight during the pregnancy. So these are the situations where you can predict fetal dystocia.
Ashima, may I please add one thing?
Yes.
Ma'am, actually, I have been training my residents in this thing, whether whenever we get a referred patient who is not delivering at their place, that's the first indication that she's not going to deliver, because they are doing deliveries in and out, the types of places we are working in. Second is prolonged first stage, second stage, another markers for having a good shoulder dystocia. And 4 kg baby is externally visible, palpable, feelable that it's going to be a huge baby. And finally, 3.3 kg in ultrasound, we should date the ultrasound also. Sometimes they get it done at 34 weeks gestation. It was 3.3 at that time. So we should be seeing when was the ultrasound done and correlate clinically also.
Very good. So lots of points we have learned. Yes, anyone wants to and anyone wants to
just can I ask?
Yeah, Leela.
Mitra was saying that we should not do a cesarean on a dead baby. In this modern obstetrics, any role of that destructive operations to take out that baby, because you don't want to give a scar on that patient. मित्रा जी
हाँ जी देखिए मतलब definitely there are two issues. If it's a very big baby and it is stuck and you're not sure about the uterine contours also, because when you are having a stuck baby of 4 kgs and you're not able to make any breakthrough, definitely if you want to do a destructive operation, that needs very intense counseling. And that's what I'm saying, that you are stuck between devil and the deep sea. And of course, if you want to avoid a scar on the uterus, you may consider doing a destructive operation and taking it out from below without giving a scar on the uterus. But one time many years ago, when we had a very bad shoulder transverse lie hand prolapse and dead baby, and patient was in obstructed labor, and we couldn't do any destructive operation, and then it was a primey, and our professor said it's better to give an intact uterus with a scar and take out that baby rather than in an obstructed labor or distended lower segment, and you cannot get the baby out from below, so you may have to do a cesarean even on a dead baby, malpresentation, stuck up, no liker. So basically, if you are sure about the contour, especially in a cephalic presentation, definitely the chances of rupture are not there. So we may be able to take out from below, but sometimes destructive operations are not so simple. Yes, in a cephalic, we may be able to
Friends, we are in the modern era. And how many of you are practicing destructive operations? I want to ask, is anyone really practicing? We talk about it theoretically, but when it comes to reality, are we really practicing these destructive operations?
The last destructive operation we've had is in an anomalous baby. In an anomalous baby.
In hydrocephalus, yes. Till date, the hydrocephalus we are doing.
Yeah. So it's only in the hydrocephalus.
In dead baby shoulder dystocia, yes, you can go with that, hidotomy and all. That can be tried. And that too with a big institute that is in the medical college. Nobody is going to do in that. But all the prerequisites should be fulfilled. Means exactly you have said, if the liker is there, if there is lower segment over stretching is there, you will not try that. So there are the conditions which are fulfilled, and definitely in this, even in this era, at the medical colleges, these procedures are going on.
Actually,
Dr. Achla will tell.
Yes, Dr. Achla. Dr. Achla, you want to say something?
No, I was saying with the text to this patient, if you have such a big baby, even if you do a destructive, you may not be able to deliver the full baby, and then you will be doing both the things, giving her the trauma of that destructive operation and the risk of injury. And also then you will have a scar. We have had a patient
mostly I think we would avoid destructive operation, and these days hardly, except for the institution, medical colleges and all, I don't think anyone is doing destructive operations these days.
Transverse lie, hand prolapse, dead baby, maybe you can do, but not in a big baby with vertex presentation and shoulder dystocia, baby dead. Better not to do.
Yes, Kavita.
एकदम सिंप्लीफाई कर देती हो.
हाँ, बोलो.
इसमें इस पेशेंट में बहुत सिंपल है कि the person who has referred this patient should have examined the records and the patient antenatally carefully in the very first stage of labor, and should have picked up the problems with 3 P's, that is passage, power and passenger. And at the same time, the points which are not exactly clear, the full dilatation is not enough. We need to know further details of the findings and the CTG findings and the pattern of fetal distress. And then we should take an appropriate decision. Each patient is unique in its way. So it has to be, such patient should be dealt not within first year house or second year. It should be someone SR, AP, and so on. So this is all I have to add on. Thank you.
I think
Thanks.
एक चीज अच्छा
Thanks,
था डॉक्टर
Kavita.
आशा.
Yeah.
डॉक्टर आशा इस केस में एक चीज अच्छी थी कि this was a good case to learn the maneuvers of shoulder dystocia.
Yes.
With a dead baby and 4 kg, you were able to take out the baby by McRoberts and suprapubic pressure, which 80 to 85% are successful. So never mind. I mean, like you've at least helped the patient, but definitely in the management at the periphery was inappropriate.
Okay. Now, next question is to Anupama. Anupama, how to predict shoulder dystocia and how to prevent shoulder dystocia?
Well, at times shoulder dystocia we may not be able to predict shoulder dystocia at times, but there are certain indicators in history like presence of diabetes, even maternal obesity, or antepartum factors like macrosomia. If you have a very big baby, there naturally would be a cephalopelvic disproportion, and you would take her up for a cesarean section rather than applying Ventouse in such situation. And some intrapartum factors, like in this case, we had a prolonged second stage, protracted descent, the baby's head is not coming down. In all these cases, we should predict that shoulder dystocia may occur. At times, even if the baby size is small, at times we may not be able to predict it. That's why it is an obstetric emergency. And all of us must know the maneuvers for shoulder dystocia.
Thank you. Sampath, now if you come across shoulder dystocia, how do you go ahead?
What, Asha? How do you?
Go ahead. How do you deliver this baby? What is your experience?
Yeah.
What is your style? Chennai Express style.
Whatever it is, if you identify with the turtle sign, the shoulder dystocia, most of the time, 90% of the cases will be delivered with the McRoberts maneuver. Bring the patient to the end and put the thigh over the abdomen as in the pictures and ask the assistant to give the fundal pressure. And like that, the McRoberts maneuver is the most effective method to deliver the shoulder dystocia patient. Nowadays, we are teaching. Now we have a lot of mannequins. With the mannequins, we are teaching for the house agents also. We have the skill labs and demonstrate how the shoulder dystocia has to be delivered. If the McRoberts maneuver is not delivered only, then we are going for the delivering of the posterior arm, bringing the hand over the chest and delivering all the maneuvers. But 90% of the shoulder dystocia will be delivered by the McRoberts maneuver. By putting this position, the diameter is automatically it is getting increased, and asking the help of the suprapubic pressure by the assistants, you can deliver that baby. So I prefer with McRoberts maneuver. As I told earlier, most of the cases will deliver with this, but you should have a liberal episiotomy, bring the patient to the end and first explain the procedure to the patient, because patient will be already psychologically disturbed. What is happening? Head has come, shoulder is not. So if it psychologically talk to the patient and proceed, you can have a good baby with a live baby itself. No, it may not be.
Can I add something? Dr. Asha, can I add something to that? So what Dr. Sampath has said, I'll just be adding a little bit. One thing is this, that the bladder should be empty. The good liberal episiotomy should be there. We should call for help and we should mark the time. Also, the neonatologist, everybody should be around. So because we know that we cannot delay, because every minute counts, but we have to go in a very methodical way, as already stated with McRoberts maneuver, when you actually extend and hyperextend the limbs and bring to the edge already it helps. The second step is to give I do both together. I do the McRoberts and the suprapubic pressure. So basically what is happening in suprapubic pressure is that the assistant with the fist actually just presses the anterior shoulder away from the midline. The idea is only that we do not want, because it is in the AP diameter, that the shoulders are stuck, they're not descending. So we want to dislodge the anterior shoulder away from the midline so that the shoulders will go into the oblique diameter, and then they will be descending down with the contraction. We don't have to give fundal pressure at all. So McRoberts and suprapubic pressure to push the shoulder away from the midline, and then this succeeds. If this doesn't happen, we have to immediately do the rotation of the shoulders. Now we can do the anterior shoulder. We have to, push one shoulder away from the midline, the posterior towards the midline. Rational सिर्फ यही है कि आप चाहे एक हाथ एक्सटीरियर एक इंटीरियर करो और आपने एक शोल्डर को अवे फ्रॉम मिडलाइन करना है, दूसरे को टुवर्ड्स करना है और उनको ओब्लिक में लाना है. If that's not possible, then go put your hand inside. We all know that posteriorly in the hollow of sacrum there's more space. So introduce your hand like a cone, take it up and bring down the arm, ensuring that there is rotation along the face. I mean, you don't hyperextend the arm, you don't fracture the arm. You have to do that gently. You have other procedures also, like putting around a catheter and rotating. Basically, अगर आप इनको डिसलॉज करके ओब्लिक में नहीं कर पा रहे हो तो आप रिवर्स करो, मतलब आर्म निकाल के. बट बेटर वुड बी दैट मेक द पेशेंट गो ऑन ऑल फोर. दैट इज Gaskins, and actually with Gaskins the gravity helps us. The baby comes down, so the diameter is already, and then you do the same procedures like rotating the shoulder. So the idea in shoulder dystocia is only that you make sure that both the shoulders are in oblique diameter so that they can come down, and hope to God that
So
they
one
are
last
baby
question to
delivered alive.
Dr. Shahla. Dr. Shahla,
may I
Dr.
add?
Shahla, if how much time
Kasha?
do we have? How much time do we have?
Can I add something before that?
Yes.
I think when a shoulder dystocia happens, before doing something, there are some things which should not be done. One, do not panic. Second, do not start giving fundal pressure. Third, do not start pulling on the baby to give traction, because this will further worsen the situation. So before you start anything, these no's should be must.
Good. Shahla, what are the timelines like? Till what time the baby is okay? For how much time do we have?
Ma'am, just 1 minute if I have to be very precise.
Yeah.
So that is why drill is a must. We have to be adequately trained so that we utilize this entire 60 minutes. It's like Chak De India ki 60 minutes to koi छीन नहीं पाएगा, but 60 minutes में कुछ नहीं किया तो we will soon lose the baby.
60 seconds. 60 seconds.
60 seconds. 6 minutes.
Yes, 60 seconds.
6 minutes. So 6 minutes is the time.
No, not 6 minutes, ma'am.
Only 60 seconds.
1 minute, 60 seconds.
60 seconds.
6 seconds. But
30 seconds.
Yeah, but it has been seen that if you go beyond 6 minutes, then the chances of the hypoxic injury are very high. So that's what I meant to say, that you don't have to really panic, but within 6 minutes, if you can do the things, that will be the best thing. 1 minute is okay. Many a times you wait for the contraction to, many people, they first deliver the head, then they wait for the contraction to occur, and then the shoulder comes. So 1 minute is okay. You don't have to panic. But you have got 6 minutes within which you can do the maneuvers and deliver the baby. Within this time frame, the baby is okay. After that, hypoxia is going to affect the baby. So that is what I wanted to ask. And about the injuries, anyone wants to say about the maternal injuries and the fetal injuries?
Actually, the most important thing to remember is that this the injuries to the baby, this is the cause for very high litigation, because the injury to the baby is very obvious, especially the brachial plexus injury. So the most important thing is that we should not tug at the neck. We should not elongate the neck and try and pull the head and try to get it out. So we have to do the maneuvers and just give the axial traction, just support the head and let these baby rotate with the contractions, and following the principle of rotating the shoulders. If we pull on the neck, it gets elongated, and then we are going to cause the brachial plexus injury, which can be paresis or complete palsy. If it has happened, we should be very vigilant and tell the neonatologist, and also advise them for early physiotherapy in case it has happened. And clavicle fracture
problems. Anyone has come across medical legal problems with shoulder dystocia? Because
no, I'm very lucky that I didn't get medical legal problem, but I remember my 2 shoulder dystocia cases where I was inexperienced. This is around 15, 17 years ago.
Dr. Leela Vyas. you would like to talk about medico-legal problems associated with shoulder dystocia? Leela is not there. Who would like to talk? Anupama?
When such an incident has occurred, we need to explain to the woman and her relatives what has happened. Now, in the end, if the baby has some neurological injury, naturally they may go to court. So it is important for us also to document each and everything. As you have already said, that 6 minutes is the time in which the baby has to be delivered. So we need to document all what maneuvers we have done, and 30 seconds is to be given to each maneuver. This is how we can save ourselves from medico-legal issues.
Yes, Asha, we have to get the consent earlier itself that some complications can happen to the baby. And as Dr. Anupama told, we have to mention the timings of all the maneuvers, 6:10, 6:12, 6:13, like that. We have to mention the times. Like if you have the documentation, means there is may not be the medico-legal problems for shoulder dystocia.
Okay, because this is such a thing which cannot be predicted so well. So if you have really done your documentation, explained to the patient and written everything, then I think you can be saved from much of the medico-legal problems.
In shoulder dystocia, each minute has to be documented. Otherwise, you can get into trouble.
Yeah. Now, next case, I think already Dr. Haresh Doshi has discussed, and that is about the impacted head during cesarean section. So I'll just talk about it. That if we give epidural, does the chances of impaction of head increase?
Not as per the evidence.
Yeah. So because many times people think that, oh, because of epidural, the problem has occurred. So I think epidural is our friend and it is not our foe. So we should really explain to the patient that this has not happened because of the epidural. And giving oxytocin, does that lead to, if the cephalopelvic disproportion is not there and you give oxytocin to the patient to augment the labor, does this give rise to impacted head?
No. If it has been used judiciously, no.
In fact, it corrects the dysfunctional uterine action. So oxytocin is not unless you've missed some undiagnosed CPD.
Okay. Now, Shehla, how long should one wait for this in second stage with the syntocinon drip and the patient has got epidural?
So we go with the FIGO guidelines. For Nully, it is 3 hours with epidural, 2 hours without epidural, and for Multi, it is 2 hours with epidural and 1 hour without. And you are the best judge.
Pushing. When do you ask the patient to push? If she's in with epidural, then when do you ask the patient to push? For after waiting for how long?
Okay, so when we see the anal gaping, the distension of anal canal, then only we ask her to push down or bear down.
And for how long?
For 1 hour, ma'am, at least. And if we wait for long, like each 15-30 minutes, they also count. Many people say that 75% of the deliveries will happen if we wait for 15 or 30 minutes. And ACOG also endorses this fact.
Okay. So if this patient has got impacted head and it is very difficult to deliver during cesarean section, what maneuver would you like to do the first? What is your maneuver of choice?
It's better to deliver
Yes,
basically there are two maneuvers, push technique and pull technique. So if you feel that it is not that much impacted, someone can push from below and then you can grasp the fetal head, it would be okay. But if you feel it is too much impacted, then the pull technique, delivering by breech, is ideal. And then the Patwardhan and modified Patwardhan techniques.
I think minimum is there when you do Patwardhan or you take out by breech, because if the impacted head is inside and you very cleanly take it out when the rest of the baby is out.
I think Patwardhan technique is really a good technique, yes.
Dr. Asha, I will share my own method because I am in a standalone practice and second stage cesareans are the most dreadful ones. So I am very, experienced in doing the push technique because, and in my own setup, what I do is, firstly, I get an assistant washed, and gloved and gowned, everything like me only. And then I have another assistant who is my first assistant. So, so that it's not, because sometimes what happens is the minute you take out your hand, again the contractions will come and the head will come down like a ball valve. It'll come again into the pelvis and again you'll have that vacuum and it'll become difficult. It'll be impacted. So I remove my hand. I ask my assistant to put her hand there and I make sure that she's comfortable. It's up. And then I clean drape. I take another gown over it, gloves and all, and then we carry on. And before putting this incision, we know we palpated that the poles are up. So this is push technique. But if I don't have a good assistant to push from below, whenever I have to do the patwardhan, my own thing is I don't do the routine fan and steel. In fact, I give the skin incision also a little higher. I do the Joel Cohen incision so that the skin incision is higher. So I can give a higher incision in the lower segment. In my personal experience, I feel you cannot do a turnaround. अगर आपने push करना है तो please push ही करिए और अगर आपने पटवर्धन करना है तो पटवर्धन planned पटवर्धन होना चाहिए. पटवर्धन push नहीं हो पा रहा तो पटवर्धन कर रहे हैं, you are stuck. So this is my learning. That's it.
Dr. Asha, if it is an anterior, most of the times, as I told, that with the Patwardhan's technique will be very useful. Delivering both the hands and then the butt. But if it is the back is posterior, in that cases, rather than going for modified, it is better to deliver as a breech. That is the practical method we will be comfortable to do.
Yeah, go for the breech.
Has anyone ever used those balloons which we see in the foreign countries?
No, fetal pillow, no, that we have not used.
Pillows you introduce to the vagina, then inflate, and that beautifully pushes up the head. Has anyone used it?
No, that's
we have only seen the videos.
You've just seen the videos, true. So what would be your advice for the future deliveries in this patient?
Elective cesarean section.
Okay, so we have to explain everything to the patient. Coming to the third case, and this is a primey 24 weeks pregnant with leaking since 2 weeks. A very precious pregnancy conceived with IVF. Previous ultrasound shows twin pregnancy, with first in breech, second in transverse. In the midnight, the registrar called that there was a cord prolapse and fetal heartbeat still present. Though the gestation was only 24 weeks, patient and her relatives insisted on saving the fetus. PV was done, cervix was almost fully dilated with cord and limb prolapse. So what would be the next process? My question is to Dr. Kavita Singh. Kavita, are you there? Kavita Singh?
Sorry, Didi, I missed the slide. Please repeat the question.
This is a patient 24 weeks with leaking and she had cord prolapse and she fully dilated cervix. So the relatives want to save the baby. So what to do next?
24 weeks?
Yeah.
24 weeks मेरे यहाँ तो नहीं बचता है.
So you are not going to, you'll just go for vaginal delivery. Anyone else wants to say?
The question of what patient wants, it is very important to look to the infrastructure, morbidity, mortality, cost, counseling.
Dr. Achla?
See, if you are asking theoretically what is to be done, then of course you cannot deliver her with the second breech there. But like
first is breech, I think.
First is breech and second is transverse.
So even this baby, when the breech is delivering, we cannot do any maneuvers if anything gets stuck. So the ideal would be to do a cesarean, but practically at 24 weeks,
we have to really counsel them.
Yes.
They were counseled against cesarean section.
Dr. Asha, I think like if somebody is really insisting, first I would definitely do a ultrasound scan to see which sac has leaked. I mean, you said that the first was breech and second is transverse lie, and she's fully dilated. So if which baby's cord has come out, is it the transverse lie which has, so we have to actually look at the ultrasound. Suppose this was not 24 weeks, suppose this was 34 weeks. How would we go about it is, we will see what is the prognosis, we'll do the ultrasound, so we know exactly.
You are mute.
Study 24 is not a...
Whichever cord is down in a twin first breech, you have to do cesarean. You cannot do vaginal delivery because if any maneuver is required, can be done.
No, Dr. Achila, 24 weeker and full dilatation can come out.
Weeks. She said 34 weeks. No?
No, I just changed it to 34 myself.
It is 24 weeks. It is 24 weeks. So ideally, you would let it go like an abortion, isn't it? Because it is 24 weeks. But because the relatives are insisting, then you cannot. Can you refuse that?
Yeah, you can. I mean, I would.
Because there are twins, we still can do a cesarean section if we want to save the babies.
You can tell them we have no nursery facilities.
24
Baby
weeks cesarean section.
going to die. But if you have facilities, then you can't refuse.
Yeah, and this is what happened, that they asked for cesarean and they wanted to save the babies because it was an IVF pregnancy, and that again 4th or 5th attempt at IVF. So we did the cesarean and one baby died, but one baby we could save. Baby stayed in the NICU for 3.5 months. And,
very creditable. I knew that you've done the cesarean and saved the baby.
Yeah, and baby has gone home now, nearly 2.5 kg, and is gaining weight and is doing all right.
Asha, don't you have that preterm retinopathy in these cases? What is about the incidence of retinopathy?
Yeah, but this baby had, but then we have done laser and everything. Our unit is very much focused for all these types of babies. So
you have to do the
yeah. So that one has been.
Congratulations, Dr. Asha. That is really good.
Asha, I have an emergency. Please excuse me.
Okay. Yes.
Thank you for the opportunity.
Yeah.
Thank you, Sampath, for joining today.
Thank you,
Sampath. Thank you, Sampath.
Thank you so much for
I
joining.
think next case I'll ask Dr. Archana to take. Dr. Archana to take. Archana, you go ahead. I'll stop sharing.
Please allow me to share the screen. Otherwise, I can just go on like that because there's nothing, no pictures on the screen. Just a case I can read.
You can read, no problem.
Yeah, because if it's not allowing to share, doesn't matter. I think it was a very nice discussion. Just like last 1 or 2 cases to finish off, because everyone has to rush to obstetric emergencies. So it's a very simple case. It's a primary who was term. There's no problem during pregnancy. At 34-week scan, we found that she's a breech presentation, breech. Then at 38 weeks, a rescan was done to confirm that it is a breech presentation. The baby weight was 3.4 kg at 38 weeks. Counseling was done and she was booked for cesarean section. What happened? The patient comes the night before. She was booked for C-section on 8th of May. She comes midnight. She called us that I'm having some leaking and little bit of pain. We told her that come as soon as possible because we know that you are a breech presentation. But as you know, that patient takes their own time and she comes at 2 a.m. in the midnight. Registrar examined her and frantically calls me, ma'am, the patient we booked for LSCS at morning has just arrived with full dilatation, membranes are absent, breech at -1, fetal heart sounds are regular, mother is in pain.
Of 3.4 kg, then we would consider a cesarean section, because in these cases, we are likely to encounter an entrapped fetal head if she delivers vaginally. So it always has to be a cesarean.
And this 3.4 kg was 2 weeks back. So we don't know what is
just 38 weeks, just few days back. So I think straightforward, everybody agrees that we should have done cesarean section. But the relative who came with her at the time of counseling during antenatal period was not there. There was her mother-in-law with her, and they said now she's in the labor. Why are you doing her cesarean section? She's had ruptured membrane. So how are you going to do a counseling, Dr. Anupama here, or anyone can check? What are the points you have to put? What we want to teach our postgraduates or the people here, okay, we take for straight away cesarean section. As an obstetrician, we find that it is the safe way to do it. But how really you convince at 2 a.m. in the morning, midnight to the relatives that in spite of being labor, why we need to do cesarean section? Just couple of
we would tell her we would counsel regarding the problems in the baby. Like if the baby is big, the head size also would be big, and we would be not able to deliver the head through vagina because of the like entrapment which may occur in those cases. So this only we have to explain. And when we tell them that there are likely chances of brain injury to the baby, they would agree most in many cases.
Okay, so I think there is no controversy. So
can I add something, Dr. Archana?
Yes, sure.
See, depending upon, there are so many ifs and buts also. A primey who had 3.4 kg breech has gone into spontaneous labor and she has come at full dilatation with breech at -1. So basically, the nature is trying to push out the baby. And if they insist on a vaginal delivery, I mean, probably there could be something that the baby weight that has been calculated is not appropriate or something. In case, I mean, obviously what Dr. Sheila and everybody has said, personally, I would also take up even full dilatation. So many times, even at the, zero station, we will do cesarean because it's too risky. And also it's a primey. Is it an extended breech or is it a flex breech? We would like to know these findings. And one thing, this is off the record. My senior one time told me, because there was a colleague who got stuck with such a case. She said, you can make out the external parts and you know how, troublesome people can be. So to, actually as an obstetrician and as saving ourselves and saving babies, cesarean is absolutely right. That should be the done thing. But sometimes we may be, really stuck up and they don't give the consent. Then we have to give them full counseling and make them write informed consent that we may be able to deliver the baby, but we cannot assure you about the asphyxia. More than the injuries, we can avoid the injuries. I'm sure nobody would cause any fractures or dislocations of a breech, but asphyxia we can't say. And here, our skills as a good obstetrician comes in. I would say that if I'm stuck to deliver a vaginally, for the after-coming head, I'll be prepared with mid-cavity forceps. I have done in my registrarship such a big baby, but it was a multi, not a primey. She came in second stage, flex breech, big feet. Just to look at the feet, we knew this is a big baby. But there was no time. So there, as a precaution, the whole body came, slowly, like all the maneuvers. But for the head, I used the after-coming head with forceps and baby came out fine. So we are afraid, but yeah, sometimes if the relatives just refuse, then we have to be very safe about the counseling, consenting. And then at the expense of the patient, you do a good job as a good obstetrician, deliver her vaginally and feel happy.
Actually, I think Shahala said something. Recently, we had one webinar with a breech, how to deliver breech with Dr. Frank, I think. So I think, what it involves is a big experience, right? If you are in an institution or a place where there are lots of vaginal breech, because in our unit, when I was there at May Day, we had a consultant, he would really insist on delivering vaginal breech, and we have done very many breech deliveries. Even we were used to do the this fetal blood sampling on the breech buttock. So that is not possible in our scenario. So I think I would agree with panelists that yes, go for straight away cesarean section, as women was already primed up for C-section. Only couple of relatives which will always be there to handle. So that's perfectly fine.
Day before yesterday, we had the similar patient, took her for cesarean, gave the spinal, and the patient said something is coming out, and we saw that the buttocks had already come out. So then we had to do vaginal delivery under spinal anesthesia. So,
and it's not, अगर my personal thing is, अगर कोई लेबर इतना बढ़िया प्रोग्रेस कर गया है कि फुल डायलिटेशन पे इतना नीचे आ गया है ब्रीच, तो आई एम श्योर कि हम पैनिक ना करें, कंसेंट पूरी लें, let it be the responsibility of the relatives, the patient, the husband, everybody. So then this is the time हम लोग करते ही थे ना.
यहाँ तो कंसेंट लेने का भी टाइम नहीं है, वहाँ आ ही गया है ना. So you can't put it back again. You have to deliver it vaginally. So the thing is that we should not lose the art of breech delivery. It is already said that she did so many breech deliveries in UK. So did I. So I feel that this is an art and we have to do it, and especially those who are in institutes, they should keep doing it. Do not lose the art. And many times people will come across emergency, and then in that situation they will not know what to do. So this art should
There's always a first time. Nai generation ko bicharo ko nahi milta, but we have all done it.
That's what I was saying. When we counsel for
external cephalic version should also be not forgotten, because when the patient was breech at 34 weeks, we could have offered her a ECV if the situation was fine. No problem.
In fact, मैं तो अगर वो sign कर देंगे तो मैं vaginal deliver करूंगी. After coming head जो है वो forceps से निकालूंगी. And I am telling you, बहुत आसाम से निकलता है. It's the easiest forceps application in an after coming head of breech.
Yes.
So I mean, let's not be scared. अगर वो consent देने को तैयार हैं, तो हमें करने में डरने की क्या बात है? जब nature ने full dilatation कर दी है और breech नीचे आ रहा है, तो ठीक है. Let them take the risk.
And residents are the most happy people. They want to see breech. So they are like, ma'am, counsel करें. हाँ, करो, counsel करो, OT में ले जाओ. Till that time, we will see. And even I'm happy if they are declining this consent.
I think we should at least try for multis. अब तो multi breach को भी कोई नहीं allow करता. सबका सीधा.
नहीं डॉक्टर अचला, एक्चुअली अगर आप डॉर्सल पोजीशन में ना कराएं और ऑन 4 कराएं तो ब्रीच डिलीवरी वजाइनली बहुत सिंपल हो जाती है.
डॉक्टर फ्रैंक ने अभी बहुत अच्छा टॉक दिया.
मैंने अटेंड किया था उनका. में पूरा अटेंड किया है.
The breach,
breach the breach.
Yes.
I think that was an excellent talk in Dr. Bakshi's VP conference. We are trying to do obstetric skill workshop, isn't it, Ashadi?
Yeah.
And probably we will be trying to get
Yeah, you should get Dr. Frank.
So Dr. Bakshi is trying. So I think hopefully
he'll be happy to come. He'll be very happy to come for your conference.
One clinical point.
Yeah.
Yes, Dr. Kavita.
Yes, Kavita.
Yeah, I just want to add on that this patient was an emergency. So one very important point is in case of breech, there are associated congenital malformations. If you're not ruled out and immediately taken for cesarean section, so please keep that in mind. That is to be done. Because
actually Dr. Archana का patient है जो कि timely था, fully counseled था for cesarean, so I presume that there would be no anomaly.
She understands. Herself is a very good sonologist, so I'm sure she's not going to miss anything.
I think she couldn't connect. Dr. Kavita's point is also valid. Though she was a booked patient, but in unbooked patient she's taking. Suppose for everyone's information, if it is an unbooked patient, you should keep in mind anomaly also. And then one point which I can add on here, I know it is not possible all the time and for everybody to have ultrasound machine in the labor room, but that can be of really great help. You cannot pick up the anomaly at term or in labor, but at least you can pick up few things. So let's move on with our last case. And last case is also very interesting. I'm sorry, I can't really share my screen due to some reason. Or maybe my screen is seen. It's a very simple case. She is again my booked primary, spontaneous twin conception, very regular antenatal checkups, and plumb normal, no medical problems, no comorbidities. And she came in spontaneous labor, both cephalic 2.4, 2.5 kg babies. Both cephalic, one twin delivered at 11:30 p.m. and second of the twin turned transverse. So how would you manage this case? I would like input of all the panelists here, and then we'll put on the second question. So transverse, baby turns transverse. My question is, how would you manage, and could it have been prevented, turning the baby transverse?
I would like to do an external cephalic version once the first baby has delivered and the second is transverse and the membranes have not ruptured. Then it is very easy to do an external version in this case.
Good.
And then
so I think it is the experience.
Can I take that question?
I'll need everyone's input because everyone will be dealing the same situation differently.
No, if anybody else wants to say
that how the experts manage, and everyone's aim is to deliver safely, whichever way they are doing. Yeah.
So I personally, Dr. Archana, I always, whenever I deliver my twins, I have an ultrasound machine. I'm very fortunate for that. And I've taken PNDT permission that I am allowed to use the ultrasound in the labor room. That is another learning point. Nobody should take their ultrasound machine in the labor room without this permission. So that is there. And I deliver all the twins with my ultrasound in the labor room. So after the first baby is delivered spontaneously, if the other becomes transverse and the membranes are intact, actually, Dr. Archila, personally, I don't take a risk in transverse lie. And even though if it may be easy, I would shift the patient to the OT and prepare for the cesarean, because transverse lie, we may or may not be able to, successfully do the version. And I'm not proficient in internal podalic version. So personally, if second becomes twin, I've had a case, but there the membranes had also ruptured and cord prolapse of the transverse lie. So I had taken from the labor room to the OT and done a section immediately, even though I had the
internal version. If this is the only indication when we can.
I know there is. I know this is the only indication, but I'm telling my proficiencies. I don't do internal podalic versions. 20 साल से ज्यादा हो गए, तो मैं सेकंड ट्रांसफर अगर हो जाता है तो मैं सिजेरियन की तैयारी करके सिजेरियन ही करती हूँ.
ठीक करते हो.
What about you, Dr. Shahala? What would you do?
IPV, ma'am. I'll do IPV with full preparation for cesarean. Until date, only 2 second twins have given me dhoka in IPV with their big cords collapsing, and once it was peripartum hemorrhage, the placenta detached. So I was unfortunate in 2 cases. Otherwise, IPV is the answer.
Dr. Kavita Singh, what would you do?
Archana, in this case, first thing I want to know what is the gestation and what is the estimated baby weight of the second one.
2.5 kg.
2.5. 2.5 kg. They are
primary or YT?
Primary 38 weeker, spontaneous onset of labor, both cephalic, but it turns transverse after delivery of the first baby.
Yeah. So in this case, if the membranes are ruptured and you can feel for the heel conveniently, because IPV का तो ये है कि OT में है patient तब तो ठीक है, patient को shifting करना ये करना, तो you have to be, if you are in the OT first, tell your anesthetist that I am trying this. If convenient, I will go for IPV for second baby. But if the second one is all well, at a good size baby, it is better to take a cesarean section. And this has to be explained to the attendants also. As Madam Mitra said, doing an ultrasound and doing it, that is the best thing.
What I do, how I do my twins, I mean, I'm sure many of you must be doing the similar thing. Whenever there is a twin, I mean, labor rooms and OT, we to have next to each other. Or maybe you can deliver them in your OT number 3 or OT somewhere, some operation theater. Anesthetist, if it's best, if it's anesthetist is around, ultrasound machine has to be around if possible, but we have, I mean, not everybody has luxury of having ultrasound machine in the labor room, so that is to be there. And one thing which I have observed and done in my practice with twins, we have an extra team, like as if we are delivering the 2 separate women, and one team is standing towards the head end of the patient, and after the delivery of the first baby, they hold the uterus so that, because what happens, like the train, when there is a more space, you like to spread and you like to turn. But if you hold the uterus, as one person just, hold the uterus like this, and then just channelize the baby, then it doesn't rotate. So that I found helpful. I don't know how many would agree with me, because long baby, if you don't allow it, there was a more liker, that's why it was trying to turn and it turned. But if you channelize it and if somebody holds it with a firm this thing, and then you rupture the membrane, then the baby will not be moving. So that's one thing which I'm doing with my second of the twin.
What you said, Dr. Archana, is very true, because this is exactly what we are also doing. We are preparing कि ये दूसरा बच्चा cephalic से ट्रांसवर्स ना हो जाए. तो जैसा आप कह रहे हो ना, मेरी भी नर्स वो हेड पकड़ के रखती है और अल्ट्रासाउंड से मैं दिखा देती हूँ कि यहाँ पर हेड है, यहाँ पकड़ के रखो, स्ट्रेट रखो. वी वेट फॉर द कंट्रैक्शंस, पेन शुरू हो जाए, हेड बीच में रख के तब एरम करते हैं. बट जैसा आप आपने बताया था कि ये ट्रांसवर्सलाई हो गया है, तो मैंने अपना बताया कि इधर 2.5 kg, I would never try to do an internal because see the cervix collapses. You know that stretch on the cervix, which is supposedly there, it collapses. You cannot assure that you will bring out a very healthy baby. Even that theoretically it's right. This is the only place where you can do an IPV.
I think everybody has different experience and different
Archana,
management
thank you so
things.
much. I have to leave. I have to go one meeting more. Thank you.
Thank you, Kavita. Thank you so much.
We should also now call it a day. Thank you.
आयुध है, छोटा बेबी है, तो आईपीवी करना है, नहीं तो नहीं करना है.
The only thing, I was asking prevention. It is management, everybody agrees either IPV or C-section, but you can prevent it from happening by doing
prevention is
that
best.
and
Right,
keeping
very
an
good.
ultrasound machine. And I normally keep 2 pediatricians separate because we had an experience once. One baby was out and it had apnea. So the pediatrician got engaged there, and the second baby also came out with a little problem. So we keep 2 pediatricians, but it's individual how and you do.
What you are saying, Dr. Archana, this is minimum. In twins, we should have 2 neonatologists.
2 teams. We should have 2 teams. That's what
we should have
basically.
anesthetists, we should have neonatologists, we should have everything ready.
So
excellent cases. Thank you so much.
I think we conclude our panel here.
I just want to say that we are forgetting the art of external cephalic version, which I still do and succeed also at maybe not all the time, maybe 30-40% of the times. So that is also good, So we should think about that also.
I think normal delivery version and all are an art. And Dr. Achula, you rightly said that we should not really forget the art, and we should learn the skills from someone who is being skilled in that particular thing, and maybe go to the institution and learn, because everybody may not have anesthetist available or like easily acceptable couple or person.
I agree.
C-section. Once you know, you can be able to do it.
Yeah, what I mean to say is that it should be talked about. Of course, it has to be done with the cesarean facility available and anesthetist, pediatrician, and patient also ready for immediate cesarean. But it is possible. We should talk about it.
Yes. Thank you so much, everyone, for joining. Thank you from bottom of our heart from 3B series, and really enjoyed interacting with you all with different, inputs, how the same case will be managed differently. And we'll stay in touch and keep, coming to our programs. So thank you very much.
Thank you so much.
Thank you for the time. Thank you for your time.
Thank you.
And
Thank you,
Dr. Dimpi, would you like to summarize and vote of thanks?
Ma'am, actually, all the topics were so well covered and with so much enthusiasm. All the panelists were answering. Shoulder dystocia and breech is very less covered generally in panel discussions. It was so good. I thank Dr. Bakshi ma'am. Even if she's injured, she is managing every time all the webinars. And Dr. Baser ma'am, thank you for bringing up the topic so well. Kavita Bapat ma'am left. Her dialogue has already been uploaded in the YouTube. I just saw. So she is so proactive, and young people like us always like proactive teachers. So I really extend my sincere vote of thanks to 3B, the Queen Bees of Indore. Your commitment towards this entire webinar is really fulfilled, ma'am. And I would like to thank Dr. Mahesh Gupta sir, Dr. Harish Doshi sir. They delivered their golden tips and tricks. I think they have left, but they really instilled, my belief in safe and happy vaginal births. And our brilliant panelists, thank you all of the madams who joined late and who left, but all of them, they were so brilliant and so excellent and so proactive. So thank you so much, all of you, to join and, give us such a magnificent event. And I thank Emcure for powering the entire webinar. Thank you so much, Pankaj Sahuji. Thank you.
Thank you, Dimpi, for really, looking after everything, from making the flyer, connecting with the panelists and the speakers. So you have been really marvelous in the
Thank you for the opportunity. Thank you. Yeah. Thank you so much.
These youngsters are an asset, for all of us.
Yes, I know.
Thank you
They
so
are
much.
all so happy, enthusiastic. They fill us with energy with their smile and the way they say, oh no, we will do it. And they are always happy and ready to do. So thank you so much.
Lovely. Thank you, ma'am. Thank you all the ma'ams and sir.
Thank you.